Okay, now we are done with the maxillary anesthetic. And as I mentioned, the most important one is the supraperiosteal anesthesia. Then maybe the infraorbital nerve block. And the other types of anesthesia are less important, but we should know about it. These are the nerve supply for the mandibular nerve, for the mandible, sorry. This is the inferior alveolar nerve, which is the cornerstone in the mandibular anesthesia. Okay, mandibular anesthesia, inferior alveolar nerve block. Can be gained through a variety of methods: Halsted approach, long buccal nerve anesthesia. No, let's go back again. Inferior alveolar nerve block can be gained through Halsted approach. Also, Go-Gates, Akinosi-Vazirani. And also we have two other types of anesthesia, which is long buccal nerve, which can be anesthetized either via block or infiltration, and the mental and incisive nerve also. So the most common technique is Halsted approach, which is the inferior alveolar nerve block. Nerve anesthetized inferior alveolar nerve, incisive, mental, and lingual nerve. Areas to be anesthetized: mandibular teeth to the midline, body of the mandible, inferior portion of the ramus, buccal mucoperiosteum, mucous membrane anterior to the mental foramen, anterior 2/3 of the tongue, and floor of the oral cavity, lingual soft tissue and periosteum by the lingual nerve. Inferior alveolar nerve block, the technique 25 gauge, long needle is preferred. Area of insertion, mucous membrane on the medial lingual side of the mandibular ramus at the intersection of two lines, one horizontal representing the height of needle insertion, the other vertical representing the anteroposterior plane of injection. The target area, inferior alveolar nerve, as it passes downward toward the mandibular foramen but before it enters into the foramen. So I am trying to, as we mentioned, it's a block. So we are targeting the nerve trunk. The nerve trunk has a canal in the mandible, the inferior alveolar canal. We are targeting the inferior alveolar nerve trunk before entering the canal. Okay? The landmark, the first landmark is the coronoid notch, and it has nothing to do with the coronoid process. Okay? The coronoid notch is a depression that you can palpate with your thumb in the ascending ramus area. Okay? It's a concavity or depression that you can feel, coronoid notch. The second landmark is the pterygomandibular raphe, which is a vertical tissue. When the patient opens his mouth wide, you can see tissue extending from the upper border to the lower border anterior to the tonsillar area. This is the pterygomandibular raphe, and occlusally the occlusal plane of the mandibular teeth. This is the horizontal landmark. Okay. The procedure, the correct position, of course, if you are giving to the right side, you should be in front of the patient. And if you are giving to the left side, you should be 10 to 11 o'clock behind the patient. After having the correct position, which we mentioned, then position the patient in a supine position or semi-supine position. The mouth should be opened wide to allow greater visibility of and access to the injection site. Locate the needle penetration site. So the black dotted line is the pterygomandibular raphe, and also you have the with your thumb you will feel the concavity or the depression, which is the coronoid notch. The area of penetration is anterior to the pterygomandibular raphe, above the occlusal plane, of course, and the concavity or your thumb will make like a landmark for the horizontal axis. This is the position, the correct positioning. Mandibular anesthesia, signs and signs. Subjective and objective. How can I know that my local anesthesia that I have given to the patient is working? Probably it is profound through subjective and objective findings, which is the subjective tingling or numbness of the lower lip indicates anesthesia of the mental nerve. Tingling or numbness of the tongue indicates anesthesia of lingual nerve. Objective, using the electrical pulse tester, can guide you to find that the successful pulpal anesthesia is there, and simply sometimes with the explorer you can check on the buccal gingiva if there is any pain. Errors in mandibular injection: too high injection along the internal oblique ridge. This results in numbness of the ear, trismus and soreness due to insertion through the lateral pterygoid muscle. Too low injection along the internal oblique ridge. The solution may be deposited in lateral pterygoid muscle, resulting in trismus. Pterygoid gland can cause parotitis and temporary facial paralysis, and posterior facial vein toxicity. But all of these complications can be avoided if the correct landmarks to be followed, and if you are sure that you are touching bone, and after you are touching bone, uh, you should assess how much of the needle is in the tissue. If it's more than half to two-thirds, you are in the correct position. You should withdraw a little and then start loading your anesthesia. If it's too deep, you can get the numbness of ear. And if it's too early touch, you can also not gain the profound anesthesia. Too medial or too posterior trauma to the superior constrictor muscle or pharynx. This is if you go too posterior either through the angulation or behind the pterygomandibular raphe, and too anterior you will lack the anesthesia effect. Complications are according to the affected area. You can gain hematoma, trismus, or facial paralysis. And of course, one of the most important landmarks that we didn't mention is the premolar area of the contralateral side. As we mentioned in the maxillary anesthesia, if you are going to give a greater palatine nerve block, you should come from the contralateral side. Also in the mandibular nerve block, the inferior alveolar nerve block, when we are targeting the inferior nerve, we mentioned that we have three landmarks, the pterygomandibular raphe and the coronoid notch, the occlusal plane, and the fourth one is the premolar area of the contralateral side that you will go through it, giving the anesthesia. Now, the long buccal nerve anesthesia can be infiltration or block. Here also I should go in a quick revision for the supply of the mandible. Of course, you are familiar with it, but let's go rapid. The mandibular supply composed of the inferior alveolar nerve that enters the canal, the inferior alveolar canal. It has a foramen between the 4 and 5 or underneath the 5, which is mental foramen. Here it branches. The one that continues inside the canal is the incisive nerve, and the one that goes out is the mental nerve. These are the two terminal branches, right? And also there is the lingual nerve and there is the long buccal nerve. The long buccal nerve is responsible for the buccal tissues for the teeth before the mental nerve. So it's responsible for the molars and sometimes for the first premolar. Okay. From the premolars, from the mental nerve and anterior to it, this is the soft tissue is the responsibility of the mental nerve, and the lingual nerve, of course, is responsible for the lingual tissues. And here is something very unique about the innervation of the mandibular teeth that, of course, if you are going to work with in the posterior teeth, you will go for nerve block, inferior alveolar nerve block. But sometimes in the anterior region, you will do infiltration. And believe it or not, infiltration in this area can be more effective than the inferior alveolar nerve block because there is some sort of decussation in the anterior area. The right inferior alveolar nerve is not limited to the right central incisor. It crosses and supplies the up to the canine of the contralateral sign, and also the left inferior alveolar nerve crosses the midline and supplies. So there is a decussation in the anterior area. That's why you cannot rely on inferior alveolar nerve block on one side to treat an anterior tooth. Okay. Now we can continue after anesthetizing the inferior alveolar nerve. Still, there is a sensation. That's why we need to anesthetize the long buccal nerve. We can anesthetize the long buccal nerve either via infiltration or block anesthesia. Infiltration, the vertical imaginary line will pass at the most distal part of the tooth to be extracted or to be treated, or just distal to it with 45-degree angle to buccal bone. You will just give 2 to 3 milliliter in a very slow rate. If I want to give block anesthesia, it will be buccal and distal to the last molar. Buccal and distal to the last molar. Okay, and the retromolar triangle at its apex. Let's say buccal and distal to the last molar. Nerve to be anesthetized is the buccal nerve. Area to be anesthetized, soft tissues and periosteum buccal to the mandibular molar teeth. The technique 25 or 27 long needle is recommended. Area of insertion, mucous membrane distal and buccal to the most distal molar tooth in the arch. Target area, buccal nerve as it passes over the anterior border of the ramus, and landmark mandibular molars and mucobuccal fold. This is the technique of giving long buccal nerve block. Now also we have go-gates technique, which is almost similar to the inferior alveolar nerve block, but at a higher level. Nerves to be anesthetized, inferior alveolar nerve, mental nerve, incisive nerve, lingual nerve, mylohyoid nerve and auriculotemporal nerve, buccal nerve in 75% of patients. Why is there more nerves involved in this anesthesia? Of course, because as I mentioned, it's higher in the level, so it is before giving these branches. I am targeting the nerve trunk before giving these branches. In the inferior alveolar nerve block, targeting the nerve after giving these branches. So I am emphasizing the inferior alveolar nerve, mental and incisive, which are the terminals of the inferior alveolar itself, and lingual nerve. But here, mylohyoid, auriculotemporal, and buccal nerve in 75% of patients. The go-gates technique, I will use 25 or 27 long needle, area of insertion, mucous membrane on the mesial of the mandibular ramus on a line from the intertrade notch to the corner of the mouth, just distal to the maxillary second molar. Target area, lateral side of the condylar neck, just below the insertion of the lateral pterygoid. So Now we will show you the picture and you will figure out the difference is in the uh, horizontal plane. Landmarks extraorally lower border of the tragus. The correct landmark is the center of the external auditory meatus, which is concealed by the tragus. Therefore, its lower border is adopted as a visual aid, corner of the mouth, and intraoral landmark is the height of injection established by placement of the needle tip just below the mesiolingual. These are the external landmarks, and this is the internal landmark. You are going with the anesthesia with the occlusal plane of the maxilla, okay? I am targeting the condyle, and the third technique is the vasiraniakinose closed mouth technique, which is also uh, not common in use, used by specialists. Nerve to be anesthetized, inferior alveolar, incisive nerve, mental and lingual and mylohyoid before giving off the branches, of course. Long needle 25 gauge is used. Area of insertion, soft tissue overlying the medial lingual border of the mandibular ramus, directly adjacent to the maxillary tuberosity at the height of the mucogingival junction, adjacent to maxillary third molar. Target area, soft tissue on the medial border of the ramus in the region of inferior alveolar lingual and mylohyoid nerves as they run inferiorly. When do we use this technique? We use this technique when we have a severe trismus or trauma, the patient can't open his mouth, or uh, although it's history now and it's a bit aggressive, sometimes it was used in pediatric dentistry, but now with the sedation and GA being a trend, there is no use of it. The landmarks mucogingival junction of the maxillary third molar, maxillary tuberosity, coronoid notch on the mandibular ramus. So it's basically the counterpart of the go gates regarding the nerves to be anesthetized and the occlusal plane of the maxilla, and we are targeting the nerve at almost at a condylar level, but the difference is this is a closed mouth technique. Mental and incisive nerve block. Nerves to be anesthetized, mental and incisive nerves. Areas anesthetized, pulps, periodontal ligament, alveolar bone, and buccal mucoperiosteal tissues of lower incisors and premolars of the side of the injection. 27 gauge short needle is recommended. Areas of insertion mucobuccal fold at or just anterior to the mental foramen. Target area mental foramen through which the mental nerve exits and inside of which the incisive nerve is located. The landmarks, mandibular premolars and mucobuccal fold. So what